Good afternoon, Assalamu alaikum. Hello to everyone from Shaukat Khana Memorial Cancer Hospital and Research Center, Lahore. We are starting our first anesthesia webinar from Shaukat Khana today. Our topic of webinar is oncological anesthesia and COVID-19. So we've got 5 presenters today. We'll start with Dr. Asma Ashraf Khan. She's a consultant anesthetist in Shaukat Khana Memorial Hospital. She has a training from Ireland and she is the first lady in Pakistan who has got CCST and has come back to Pakistan with the CCST of anesthesia. So she is going to give us a talk today about airway guideline and protection of the anesthetist. So I welcome Dr. Asma Ashraf. Please.
Thank you so much, Romana. So my talk is about the airway management principle in COVID-19 and protection of the anesthetist. As we all know that SARS-CoV-2 virus is a highly contagious with an R naught of 2 to 2.5, and it has emerged as a global challenge to the medical system, and the clinicians and the healthcare workers are in the forefront battling the disease. So that's why the literature from all over the world, including from China and Italy, has shown that the healthcare workers are at increased risk of contracting the illness, particularly during the aerosol generating procedures. And the purpose of this talk is that how can we mitigate that risk to the healthcare worker, especially the people who are managing the airway. And for that, we need to focus on certain things. We need to know how the virus transmits itself, what is the risk associated with the aerosol generating procedure, how can we change the institutional systems to prevent the infection of the healthcare worker, and then work at the departmental or individual levels to prevent the contamination and infection of the healthcare worker. Most of the information I'm going to discuss today that has been drawn from these societies, and more importantly from the experiences of the clinicians from all over. This is the consensus guideline which has been published recently by Tim Cook and colleagues, who has done a lot of work on the airway. He's from UK, and they have mentioned that we should focus on the safe, accurate, and swift management while we are dealing with the airways of patients with COVID-19. The routes of the transmission, if we talk about, I know Dr. On is going to talk more about it, but basically for the COVID-19, it transmits itself like any other respiratory tract infections through droplets and through direct contact with the patient or with the contaminated surfaces, and the virus is known to be viable on the surfaces for up to 72 hours even. The droplets transmission is the main route of transmission, along with the contact transmission, and the droplets are actually of 2 types. They are either small, larger particles which are more than 5 micrometer, and which are called the respiratory droplets, and they kind of cause the local spread in an area within a meter. But the airborne transmission, I would say, is something different. This is transmitted through droplet nuclei, which is less than 5 micrometer in diameter, and they harbor the microbe. The thing about them is they can remain in the air for a longer period of time, and they can also be transmitted to others over distances much more than a meter. So our focus should be on the droplet transmission and physical contact, though the risk of the airborne transmission should be kept in mind, but the risk is quite low. It becomes quite significant in certain circumstances depending upon the patient factors and the interventions which are done on the patients. For example, the critically ill and the sicker patients tend to have more viral load. Some patients are super shedders with enhanced ability to transmit, then more coughing, sneezing. Tachypnic patients, the longer time spent with those patients can result in more risk of airborne transmission. And then more importantly, the aerosol generating procedures like tracheal intubation, tracheostomy, emergency front of neck access, non-invasive ventilation and mask ventilation are known to produce aerosols. Disconnection of the ventilatory circuits is also can cause the airborne transmission, along with the tracheal extubation and cardiopulmonary resuscitation before the tracheal intubation, as well as bronchoscopy and tracheal suction without a closed inline. You have noticed that I didn't mention about the laryngeal mask and the aerosol risk because there are no studies actually done. Most of the information which is gathered about is based on expert opinion, which suggests that there is greater risk of aerosol generation with laryngeal mask as compared to tracheal intubation, but obviously it's less than the face mask ventilation. Though the laryngeal mask seals airway at low pressure, and that works out well for most of the patients who are COVID negative and who are not symptomatic, but high positive pressure, if used in LMA, it might create a leak with aerosol production. So therefore, the important thing is that a risk assessment is done based upon the community spread, and if there's a high community spread, expert opinion discourages its use. And then there is a lot of things about the nasal flow. Nasal flow, again, there is not a lot of studies done on the viral spread through the high flow nasal oxygen, but the bacterial transmission has been assessed as low, but depending upon the, because of the many reasons like the mass illness and mass mechanical ventilation needed in the pandemic, its use is currently not recommended around the time of the tracheal intubation. Now we talk about the institutional steps which can be taken to prevent the infection of the healthcare worker, and the National Institute of Occupational Safety and Health have actually proposed a model to control the hazards in a workplace, and that can be easily applied to the infection control model. And we have actually very nicely done in our hospital in as this pyramid shows that for the infection control, the main segments are constituted by elimination and the engineering control within the hospital. So elimination means that we remove the entry of the pathogen into the hospital, which is brought obviously either by the employees or the patients. So we have a very good screening system for the employees which are working in the clinical area, and the symptomatic patient is screened outside the hospital in the hospital triage, and then we have pre-op screening for the patients who are presenting for elective surgery. And then we talk about the engineering control, which I think are really important when you are dealing with a pandemic like COVID-19. And engineering controls are basically the hospital designs and structure and the setup to remove the opportunity for pathogen exposure. And amongst these, the negative pressure rooms are very important because they reduce the viral load outside the room. If the airborne isolation rooms are not available, obviously we can rely on the single room with closed doors, and we can incorporate HEPA filters, though they are not a substitute for the negative airflow, but it can be considered to reduce the risk in a single room. And as the critical care is expanded to other areas of the hospital in many places in the world, and probably in Pakistan as well, most theaters could be used to actually provide care for the patients who are positive. And in that case, the operating rooms which are positive pressure, they could be risky ventures. So what we can do is that, and which we have done, is that we have increased the air exchanges in the operation rooms here from 20 plus per hour to decrease the viral load within the theaters. And then the administrative controls are important to prevent the infections. For example, the work policies and procedures that prevent the pathogen exposure, and hand hygiene is essential in that. And the Anesthesia Patient Safety Foundation has suggested that not only during the 5 moments of hand hygiene, but in this pandemic, there are certain other areas which the healthcare workers should pay special attention to. And these are the hand hygiene before and after donning or doffing of the PPE, before touching the anesthesia machine, anesthesia cart or content, when you are working in the operating rooms, and then each time when you contact the patient, after you remove the gloves or you are in contact with the soiled or contaminated areas, the hand hygiene should be done, and the hospital should provide enough supplies for the hand gels and rubs, and train the individuals. And do not forget the surfaces. In OR and the intensive care, they have a lot of surfaces which can harbor the aerosol, which can actually serve as a good reservoir for the virus. So these surfaces should be contaminated, followed by the safe disposal of the waste, and also maintaining the social distances, not only in the community and outside the operating rooms and intensive care, but inside the operating room as well. For example, do not congregate at the workplace, and when you are sitting in the doctor's lounge, or the patients are in the holding bay or in the PACU, they should be distanced with each other. And the PPE, as you can see, it forms only the part of the system to prevent the infection of the healthcare workers. But it is extremely important. It does work. It has been shown by the SARS epidemic as well. There is no substitute for full appropriate PPE for aerosol generating procedures, and staff should take that into consideration. More importantly, the training and mock drills in PPE use, especially in the doffing steps, and the hand hygiene during the doffing steps is extremely important. In many places, a buddy system has been introduced along with checklists, like the way we have checklists in the donning and doffing area and intensive care. That helps a lot to the healthcare workers. Then whenever you use PPE, use correct, they should be checked. Airborne precautions are minimal appropriate. They should be simple to remove. They should cover the whole body, neck, and they should be disposable and should be disposed of appropriately and immediately after. There is a lot of talk about the shortage of the mask, N95 mask. We have devised a system to reuse it and use it for the and extended use purposes as well. We have tried that, and so basic thing is that the PPE needs to be safe, sufficient, and it should be used in a manner that supplies remain sustainable. Goggles and face shield are really helpful. Especially the face shield will protect not only the eyes but also the N95 mask from contaminated mist and droplet which are produced during the coughing. I will emphasize a lot on the double gloving, which might provide extra protection and minimize the spread by fomite contamination of equipment and surrounding during the airway management. And these gloves should be removed immediately after the airway manipulation. This is just a picture which shows the contamination which can occur with the dirty hands or contaminated gloves if they are not removed immediately. And the star shows that the areas which were touched by the hands of the anesthetist. So it shows that the patient zones, anesthesia machine, the supply cart, arms, and even floor can be contaminated with those secretions. Peppers are used. I'm not going to talk a lot about them, but they have more protection, but obviously they are challenging to wear, and their cleaning can be a problem, and we need to. And finally, I come to the strategy, the airway strategy. We did talk about the institutions, but then the departments and at individual levels, we have to think about a proper airway strategy with backup plan for these patients who could be really sick. So this segment will actually hover around the choice of the personnel, the selection of the equipment, and the technique which has to be adopted. So we are doing the intubations either in the intensive care emergency for the patients who come with respiratory distress, but as the epidemic is increasing, more and more asymptomatic patients or patients with mild disease, they are presenting for emergency surgery or for unrelated. And when we are dealing with that patient, what things we should focus on? So airway personnel is important, and most of the guidelines recommend that the most senior anesthetist should do the management, and that is because the focus is on the safety and the swiftness. So ensure high probability of success at the first attempt, because as the multiple attempts are done, they're likely to increase the exposure to the staff during the aerosol generating procedure. Again, it is important that in the room where the intubation is done, there are smallest number of the staff, and this is just picture shows that we have allocated the roles. So 3 people inside the room and 1 is the runner. So intubator, 1 is intubator, the second one does the cricoid and also hands over the airway equipment, and the third one does the drugs and monitors the patient's vital signs as well, and the runner watches from outside and calls for help if it is needed. So when we talk about it, who should do the intubation, just have to think about the people or the staff who shouldn't be involved in the airway management. And there is no guidance, but the current evidence suggests that there will be few people who would be higher risk, like older staff, the patient with cardiac or respiratory disease or recent cancer, diabetes, and probably hypertension as well. Then also immunosuppressed pregnant patients shouldn't be involved in the airway management of the COVID-19 patients if possible. And then the equipment becomes important. So this is general equipment which will be needed for intubation of a COVID patient. So it contains everything along with the tubes, the germs, and C-circuit, which should be either disposable or should be decontaminated. And video laryngoscope and a tube clamp is necessary, and we're going to talk why they are important. The emergency front of neck kit should be in that equipment. So we in our hospital has made these packs. As you can see that there is a list, and according to that list of equipment and drugs, we have prepared the trays or the packs, and one pack has to go inside so that it does, if it is not, even if it is not used, the things will be either disposed of or decontaminated. And the outside tray contains the laryngeal mask or the emergency front of neck access. There is a lot of debate about the single-use versus reusable. The public health England suggests that we should use single-use equipment, but obviously they may not be available or they may not be of the same quality. Supplies may run short, so in that case, reusable equipment might have to be used, and care should be taken that they are appropriately decontaminated, so that the risk to the staff, not only the frontliner, but also those who are involved in the transport and decontamination of that equipment, that should be that they are not exposed to that risk. Technique is important. It is almost the same for both emergency and non-emergency, but we should try to do planned intubations rather than crash intubations, so the staff has time to safely don the PPEs. Do not use the techniques that haven't been used before, because the accuracy is quite critical. So you need to use the techniques that you are familiar with, and they are also known to work reliably with a wide range of patients, especially when the difficulty is encountered. Awake fiber optic intubation is obviously is avoided unless it is specifically indicated to reduce the risk of aerosolization of the local anesthetic. Before you enter into the room, it is important that you have a checklist available. There are various checklists, and we have one in our setup as well, and it's almost the same as like this. Once you are outside the room, just to recap, you have put on your PPE, you have allocated your personnel, now you have prepared your equipment and drugs, and you have also planned for your difficulty. If it is encountered, that what is your plan C and D, and that is actually taken from the simplified DAS guidelines for the airway, that was from 2018. Once you are inside the room, you have to make sure that your patient is optimally positioned in a ramped up. You have an HME filter, which is a good quality between the face mask and the tube and the circuit to avoid contamination of the atmosphere. The capnogram or the sample line, that should be distal to the filter. This is important again to avoid the contamination of the environment. Then you start reoxygenating the patient. This patient, obviously, if they are symptomatic, they might be intensive care, they will be desaturating, so you need to apply the mask with a tight seal with high flow of oxygen. You try to keep the flows to minimal, but that depends what your patient needs. The VE grip is recommended as compared to CE grip because that seems to work more efficiently, especially in the difficult airways. And then we use this plastic sheet that works as a barrier for the aerosols. A rapid sequence induction approach is obviously the one which is advocated with or without record pressure, and then you use your drug according to the patient's condition. The vasopressors should be available, and then is the most important thing, the neuromuscular blockade. You should ensure that is a good neuromuscular blockade before the tracheal intubation is attempted. It should be in an appropriate dose, and the dose for success, for example, 1.5 for ROC is 1.2 milligram per kg. And avoid bag mask ventilation. The reason again is to prevent a potential aerosolization of virus. Gentle CPAP may be applied with a good seal to avoid the need for bag mask ventilation. Still, these patients, because they're sick, they may need bag mask, and if that has to be done, that has to be done with low oxygen flows, low airway pressures, and small tidal volumes. And if needed, a supraglottic airway device can be used. Then we finally come to the laryngoscopy. So laryngoscopy is done with any piece of equipment which works best, and it is said that the video laryngoscope with a separate screen works best in this situation because it enables the operator to stay further away from the patient's airway. Obviously, if you're not trained in its use, you can't use it. And if it is not available, then a standard Macintosh plate and a bougie, which is either preloaded with the tube or is immediately available, is likely the best option. Make sure that when you are removing the bougie or stellate, you do not spray the secretion around. Then once you have done your intubation, you will inflate the cuff, and the important thing is that you do not start your mechanical ventilation. You start it only after the cuff is inflated, and you will check the capnogram. There are few recommendations that because with the airborne PP, the auscultation of chest would be difficult, and also it is likely to contaminate the stethoscope, and therefore it's not recommended the use of the stethoscope. But if you have a dedicated stethoscope in the room, obviously you can use it. Once you have done that, then you can resheath the laryngoscope in the one of the gloves, because you are double gloving, so that one of the glove can be used to resheath the laryngoscope and can put in the double ziplock bag, and before transferring it for proper decontamination and infection. So airway management doesn't actually, as the epidemic is waning, we will see the patient coming for the routine surgeries as well. The thing here to keep in mind is that that patient may be asymptomatic with COVID-19, but they may be infected. So obviously symptomatic patients are more infectious, but I would say that you should have a low threshold for considering a patient at risk of being infected, and it may become necessary to treat all airway interventions as high risk, especially as the number of the asymptomatic carriers is increasing. If we encountered the patients in operating rooms with confirmed COVID-19 infection, then they should be brought obviously directly to the OR rather than going to holding bay, and they are recovered in the OR. Or if they have to be kept intubated, or they have coming from ICU, then they should be brought back to the negative pressure rooms in ICU and extubated over bottom point. Again, these patients make sure that all the medical devices in the OR are covered with the disposable plastic sheet. Drug choices may differ because these patients may not be as sick as the critically ill patients. Have a lower threshold for a supraglottic airway device over face mask ventilation, and lower threshold for tracheal intubation as compared to supraglottic airway device. If you use supraglottic airway device, spontaneous ventilation is preferred to control ventilation because airway leak is less with spontaneous ventilation. Again, resheath your laryngoscope, and this is after you have done the intubation. These are important stuff you have to think about. The side is a little bit blurred, but avoid unnecessary circuit disconnection. If disconnection has to be done, wear PP, stand by the ventilator, and clamp the tube before you disconnect the circuit. Strict adherence to the de-gowning or doffing steps. And remember that between the doffing steps and the hand hygiene, do not touch your hair and face. And this should be followed by a team briefing. I'm just going to talk a little bit about the barrier techniques. They are used a lot. They may aid in reducing the viral load into the room, but they do not lessen the need for effective PPE, so the PPE should be worn all the time. There is no substantial data on their effectiveness, and some people think that actually it may slow down the intubation time. There have been a lot of things. This aerosol box has been recommended. It improves the visibility, but it requires construction of the device. The disinfection can be a problem, and if the patient has a difficult airway, the manipulation of the airway through those circular holes can be difficult. Plastic drape technique I find much more simpler. It's inexpensive and it can be used for pre-oxygenation and also for the intubation. But make sure that you do not generate further aerosol while you're removing the drape. And some the authors have written that the sheet can be left in the place for the duration of the surgery and can be subsequently, patient can be extubated under the same drape. This is a modified technique which is used, in which I feel that it improves the success rate of the initial intubation attempt, especially when a difficult airway is encountered, and instead of the whole circuit beneath the drape, actually there is hole for the mask. So that technique can also be used. The plastic curtains, they have been introduced, and again, their efficacy we don't know about. Extubation in COVID positive patient, again the same rules, do the suction, consider prophylactic antiemetics, minimize the coughing with the help of the drugs, or you can use supraglottic airway device to use as a bridge to extubation, and the extubation should be done under the plastic drapes and immediately put the patient on the oxygen, and patient should be wearing a face mask as well as their oxygen mask and nasal cannula, whatever is practical. And this is the just a picture to show that patient has been extubated under the drape, and then the drape has been used to wrap the airway equipment. Just to summarize, these are the things we, as an airway strategy, should be used before, during, and during the intubation and after the intubation. And the important points are the hand hygiene, negative pressure rooms, PPEs, minimum people during the aerosol generating procedure, closed suctioning, viral filter, video laryngoscopes are important. Senior personnel should be doing it. Pre-oxygenation with 2 hand grips, ensure paralysis, ensure lower gas flows, positive pressure ventilation only after cough inflation, and after the intubation, minimize the circle disconnections and strict adherence to the proper doffing steps and hand hygiene, and cross-monitoring by all team members for any potential contamination. Thank you.
So thank you, Dr. Asma Ashraf. Our next speaker is Dr. Athar Mukhtar Siddiqui. Dr. Athar has worked in Pakistan Army as a consultant after doing his FCPS, and then he moved to UK, and he has worked in United Kingdom in NHS for another 18 years as a consultant. He looks after anesthesia and critical care unit in Shaukat Khana Memorial Hospital for the past 5 years. He has a vast knowledge of literature and religion. But today he is going to talk to us about controversies in current COVID-19 management. So I welcome Dr. Athar Mukhtar.
Bismillah ar-Rahman ar-Rahim. Right, the COVID is deceptive right from inception, and whatever aspect of the COVID infection you look into it, you will find a lot of controversies in it. So I'm not going to talk about the geopolitical controversies. I'm not going to talk about how did it start, who's blaming, who's pointing out fingers on whom, and how it was spread. I'm just going to focus on that what are the current controversies in the management of the corona infection patients. The first controversy which arose in our minds was whether it gives an ARDS picture or it's a diffuse alveolar disorder. So a controversy started after recent Italian autopsies report whether COVID-19 is ARDS or that established ARDS therapies are inappropriate or they may cause harm in the patients. So ARDS is an acute syndrome of hypoxia, we all understand. And we all understand it's not a disease, but we know that it's a final common pathway of lung injury, which could be iatrogenic in nature because of the fluid overload, ventilator-induced lung injury, or because of the host responses. But all of them, they are debatable. So diffuse alveolar damage is often regarded as the key pathological findings in ARDS, and that has been reported by Barton in last month. Now, however, others, they argue that diffuse alveolar disorder is not a universal feature of COVID-19 pneumonia at autopsies, which was reported by Magro again in the last month as well. So does this mean that COVID-19 is not ARDS? We are not yet sure. Now, even before the COVID-19 pandemic, less than 50% of all the ARDS patients, they had diffuse alveolar damage at autopsies, which was reported by Thill in 2013. Now, why do insist on ARDS? Because probably, in my opinion, it is convenient for the clinicians to provide appropriate therapies and prognostication and to group the various signs and symptoms of the patients under one umbrella and utilize that umbrella for the purpose of research and allows heterogeneous patient groups to be studied in adequately powered clinical trials. So different ARDS phenotypes have been reported recently, just in the last 2 months. At least a subtype of COVID patients have preserved lung compliance, which you and me as clinicians have experienced, that these patients, they present with silent hypoxemia. It was an interesting article by Gattinoni in which he suggested a framework for how to manage the COVID-19 patients. However, the CALPHI in 2014 analyzed 2 major ARDS distinct sub-phenotypes. That was after the Middle Eastern SARS epidemic, and in which in the RCTs, he looked and he labeled the 2 different phenotypes as either the hyperinflammatory phenotype or the hypoinflammatory phenotype of the ARDS. However, there are few patient data available and certainly no experimental evidence so far to support this model, and the proposed implications for patient management are still awaited. Furthermore, some patients with silent hypoxia and good lung compliance, they improve their oxygenation with prone positioning. When this happens, and that is in the experience, and the anecdotal experience of mine and a few of other friends of mine, this does not quite fit the expected response in the model described by Gattinoni. So, which implies that these patients should be less prone responsive. Now, the other controversy which was published in the Lancet about COVID was whether it is a coagulopathy or it is an ARDS. So it is now clear that among hospitalized patients with COVID-19 pneumonia, sepsis and respiratory failures are frequent complications, with some patients developing severe systemic disease and multi-organ failure. Now, the combination of immobility, systemic inflammation, platelet activation, endothelial dysfunction, and stasis of the blood flow can lead to coagulation. COVID-19 associated with thrombotic complications seem to resemble other systemic coagulopathies. Now, like DIC. Now, besides elevated D dimers and fibrinogen, patients with severe COVID-19 have a mild prolongation of prothrombin time, and thrombocytopenia is uncommon at admission, which is quite contrary to the DIC, while patients with the DIC commonly have prolonged prothrombin time and thrombocytopenia. So a central question arises that could inform the prevention, diagnosis, and treatment strategies of COVID-19 coagulopathy remains under debate are the hemostatic changes as a consequence of the coagulopathy. Now, considering the coagulopathy, the anticoagulants have been used in the treatment of COVID. So the anticoagulant treatment, this paper was published by a Chinese group, and this is another paper which was published by the Dutch group, in which they looked at that despite prophylaxis, 31% of the incidence of thrombotic complications were there in the ICU population. Then the PE was in 27% of the patient, and there were arterial thrombotic events also reported. Another study, which is a French study, which was published in Intensive Care Medicine, they looked at the incidence of pulmonary embolism at 17% among their patients, whereas the CRRT circuit clotting was found to be 96%, and the ECMO circuit, though all those patients who were put on ECMO circuit, the ECMO circuit clot was found to have an incidence of 8%. 95% of the patients had elevated D-dimers and fibrinogen, whereas no patient developed DIC. 87% of the patient tested positive for lupus anticoagulant, whereas there was matched ARDS non-COVID-17 versus 2.1 pulmonary embolism as complication noted. So the controversy is still there. Is it still a DIC when we find the PT and the APTT normal, when the platelets are usually raised and there is no thrombocytopenia, when the D-dimers are raised and the fibrinogen level is raised, and the peripheral blood films, when they are looked into the microscope, they are unremarkable. The next controversy, which among the clinician, especially dealing in the high dependency unit, is whether to use the closed circuit versus the non-invasive ventilation. And we found out that a good interface fitting for CPAP or NIV systems minimize widespread dispersion of the exhaled and consequently should be associated with the low risk of airborne transmission from patients. So by minimizing the aerosolization, but in an environment where the facilities of the equipment and the expertise of the people who are looking after the COVID patients is really scarce, can we make sure that all these patients, they can have a good interface fitting, and all those patients who are provided with the CPAP or the NIV are safe for the people around, and that is suitable. So the endotracheal intubation was associated with an increased risk of aerosolization and infection of healthcare workers, which was picked up in a Canadian study. And that is the study which was conducted in a few years ago, and this was not conducted among this COVID environment, and they found out that greater risk of the developing severe acute respiratory distress syndrome among the physician and nurses who performed the endotracheal intubation as compared to those who were just looking after the patient. Then the recent solidarity trial by the WHO also created a controversy, and in itself they were looking at the 4 drugs. They were looking at the remdesivir, they were looking at the lopinavir and the ritonavir combined, they were looking at the lopinavir, ritonavir combined with interferon beta, and they were looking at the hydroxychloroquine with the azithromycine. And due to the safety concerns and evidence of the arrhythmias leading to higher death rates, the WHO suspended the hydroxychloroquine arm of the solidarity trial in late May, just last month. So That was quite a big trial in which they enrolled more than 3,500 patients from 17 countries across the continent. So the next controversy exists about the steroids. So among patients with non-severe disease, should steroid be used or they are beneficial or not? Among patients with more severe disease, steroid improved survival. So let's look at the evidence in the literature. So that was a study which highlighted the effects of early corticosteroid treatment in plasma SARS-associated coronavirus, and that was published in 2004. And this was another study a Chinese study which showed that steroid therapy correlated with more rapid improvement in oxygenation and radiographic abnormalities. And the patients treated with methylprednisolone were weaned off from oxygen earlier as compared to those who did not get the steroids. This study was published in JAMA, in which they looked at the various risk factors associated with the ARDS syndrome and death in patients with coronavirus 19. And they figured it out that the older age was associated with a greater risk of development of ARDS and death likely owing to less vigorous immune response, although higher fever was associated with the development of the ARDS. It was also associated with better outcomes in patients with ARDS. Moreover, treatment and methylprednisolone may be beneficial. So again, ARDS and prednisolone and all these controversial things, they were included into the risk factors. The Lancet published this just a few days ago, just exactly 10 days ago, a caution against the corticosteroid-based COVID-19 treatment, in which they cautioned that in a retrospective study where they looked into the 539 patients who received the corticosteroid therapy, the incidence of the steroid-induced osteonecrosis of the femoral head was 24% prevalent, and increased incidence of steroid-induced osteonecrosis of femoral head was associated with the total corticosteroid dose and the use of more than one type of corticosteroid. So where do we stand? To sum up the steroid story, no prospective RCTs are still available. The steroid is usually administered to the sickest patients. Nonetheless, steroid administration generally correlated with improved outcomes. This suggests that steroid may be having a causing benefit. The most controversial hydroxychloroquine and the most controversial combination of hydroxychloroquine with azithromycine. It may act because of the possible synergy between the two drugs. The observational studies were made by Gottret and published in International Journal of Antimicrobe and by Rosenberg in the last 2 months. Whereas I just mentioned earlier on that in the Solidarity trial, after enrolling more than 3,500 patients, WHO stopped this arm of the trial where they were using the hydroxychloroquine because of the cardiac arrest, which was more common due to the QT prolongation. So the summary which the Lancet published was that when compared with mortality in the control group, hydroxychloroquine hazard ratio was 18%, with 95% confidence interval of 1.223 with the macrolide, and chloroquine with the macrolide were each independently associated with an increased risk of in-hospital mortality. The next controversial is antiviral medicines are lopinavir and daratumumab, which are the viral protease inhibitors. Kao published his article in New England Journal of Medicine just 2 months ago, which was a randomized controlled trial in which he recruited almost 200 patients, and he allocated lopinavir and ritonavir to one group of patients versus supportive treatment according to their local protocols. And he observed that there was no difference between the two groups as far as the outcome was confirmed, and the outcome was that there was no difference in viral decay. However, there were some collateral damage in terms of QT prolongation, hepatotoxicity, and some GI effects. The tocilizumab, is another drug which is very attractive, IL-6 receptor inhibitor. It causes immunosuppression, causes HBV and TB reactivation, hypersensitivity reaction, hepatotoxicity. Should we use it or not? The results are promising, but no major RCTs are still available. The last thing is the convalescent plasma, which gives a passive immunity. And in JAMA recently, a few case reports have been published in which the 8 patients who were ventilated, 4 extubated at the time of data. It was a small sample size, not adjusted for other co-treatments, and other drug administrations were there like lopinavir and ritonavir and interferon. So we don't know which acted, but there is a good impression about convalescent plasma that yes, it could be. So following plasma transfusion, the body temperature normalized within 3 days in 4 of 5 patients in a case series of 5 critically ill patients published in JAMA, in which the SOFA score improved and the PO2 FiO2 ratio that increased within the 12 days. And in another paper published in Science, in which they figured out that neutralizing antibodies could be antiviral against COVID-19 pandemics. In New England Journal of Medicine, they found out, interestingly, that angiotensin-converting enzyme inhibitors were more common among survivors than those who died in a multivariable model. Higher risk of deaths, they were associated with age of more than 65. Now, the same angiotensin-converting enzyme 2 is highly expressed among the smokers' epithelium as well. So that is also a controversy, that whether the smokers, they behave better as compared to the non-smokers or not. The remdesivir, the most talked about drug, as Pakistan is one of the few countries which produce it. It is an RNA-dependent RNA polymerase inhibitor, and the Green published its result in just less than a month ago in New England Journal of Medicine, and Bang reported in Lancet in the same month. So remdesivir versus standard care improved 63% of the patients with only 13% mortality. However, there were some GI effects and hepatotoxicities. It's a promising drug and it needs further well-controlled trials. So this paper was published in New England Journal of Medicine, in which they looked at the remdesivir, and they found out that the patients who received remdesivir had a better outcome as compared to the other drugs. It was a double-blind study which was conducted in February, and it enrolled a large number of patients, more than 1,000 participants in 10 different countries over 60 days across the globe, and 538 received remdesivir and 521 received the placebo. The Lancet published a summary about it, and they found out that although not statistically significant, patients receiving remdesivir had a numerically faster time to clinical improvement than those receiving placebo. The New England Journal of Medicine published this in the last month, and they found out that this report was based on the data from the patients who received remdesivir during the period from January 25th to the March 7, 20th, and have clinical data for at least one subsequent day. And they found out that it was beneficial. So in a randomized controlled trial, people who received interferon beta, ribavirin, and lopinavir and ritonavir, a combination therapy for the COVID, is another controversy which is still undergoing through a phase 2 trial. It's a randomized controlled trial, and it's an open label trial, and let's see what will be the result of this trial. So this is something which I have already mentioned, that heightened ACE2 receptor in the airway epithelium of the smokers, and COVID therapy, are we missing the optimal treatment window among these controversies or not? So that is the biggest question what we have got in front of us. The other main question is that should we start with the routine surgical elective procedures in our operation theatre or not? In the West, they have got their problems, but over here we have our own specific problems. They have got their problems of insufficient number of staff, insufficient anesthetics, insufficient supplies of personal protective equipments and other things, whereas we have certain other issues over here. Thank you very much.
Thank you very much, Dr. Athar. Now, our next speaker is Dr. Syed Raza Mehdi. He is a consultant in Shaukat Khana Memorial Hospital in the Department of Anesthesia, and he is doing the toughest job, which is known as a very thankless job. He is a rota in charge for the past 5 years. He has done his fellowship from College of Physicians and Surgeons, Pakistan, years ago, and then he moved to Ireland in year 2000 and worked there. He was my teacher as well, and he has taught me a lot. And today he is going to tell us the staffing issues that we have came across during this difficult time. So over to Dr. Raza.
Assalamu alaikum. Thank you for the kind introduction, and I'm going to talk about this problem from a quite different angles, previously from the physiology, pathology, but I'm talking about from the point of view of demographic aspect of the COVID and its effect on our staffing level and the problem faced by the hospitals in general. So this was this study published in 2015 in Emergency Medicine, and what they find out when the pandemic, special pandemic strikes, the most risk of inadequate supply is the staff. So we have to preserve our staff to work for the pandemic, and after pandemic is over, we will need the trained staff as well at that stage. A quick look. You might be familiar with this graph, which is actually updated every day. This is 2 days ago, and it simply shows the different death rate in different countries of the world. And look at the graph. As far as the number of the deaths are concerned, Pakistan is not at the top. But if you look at the pattern of the graph, you will realize there is something unwanted or undesirable in the, statistically speaking, in the number of the deaths, because most of the graphs ranging from South Korea, Japan, China, Iran, US, they looks like the curve is flattening. But in case of Pakistan, the curve is still rising. We haven't seen the concept of flattening of the curve yet. Maybe different reasons, but we should be ready for more deaths prevailing in our country, in our society. It's a problem, and we should, as a healthcare worker, we should be ready to face this phenomena in coming days or weeks, I would say. The other interesting terminology we are seeing in our media about this pandemic, as I mentioned, was the concept, the flattening of the curve. Keep it very simple. In Pakistan or in Lahore, we are not seeing this flattening of the curve at the minute. The people in the world have started talking about the second peak effect of this pandemic, but we still not have the first peak, so we should be worried. Now the question comes, should we be doing the elective surgeries in a hospital setup, in an anesthetic setup, in OR setup? I would suggest it's a misnomer. There's a concept developed, it's basically the American College of Surgeons, which developed this concept of medically necessary time-sensitive surgeries. And especially from the Shaukat Khana point of view, most of our surgeries fall into this category. So we cannot deny these patients who may not be emergency, but they definitely medically necessary and time-sensitive. If we delay the surgery, the disease is going to uncontrolled and is going to be a prolonged effect on the family and the patient. Then comes this equation, equation of risk to the healthcare staff from the patient versus the risk to the patient from the surgery and staffing. So when we are planning any OR work, we have to look into this point as well. There's a number of scoring systems is developed by different societies about how to prioritize the cases from the procedure and disease point of view, but also from the hospital resources point of view, such as PPEs, blood availability of blood, ICU bed, or the regular bed or capacity of the hospital, which we are talking about. The essential points are, this is an interesting phrase that we should be planning in calm for the staffing in pandemic. So we can't plan these issues when there is a pandemic. It should be planned ahead of it. The interesting thing about this fact is that in Pakistan, we haven't, up till now, we haven't faced any pandemic. We haven't faced SARS or the MERS or the Ebola virus, but some countries who has gone through these pandemics, they are rather more planned in facing the current pandemic. We are concerned with the patient safety and healthcare worker protection. We want to minimize the exposure to our staff and to also to the exposure to the patients as well. On the other hand, purely from the training point of view, we are facing this issue of long and short-term training. Short-term training, I mean, how to face this current situation, and long-term training, as you might understand from the medical point of view and from the other aspect, how to train the doctors in general. How to limit the staffing and how to provide the essential services going on during this period. And just keep on remember there's physical and psychological point of view. It is a stressful period, so we need to provide support to our staff who is working during this pandemic. There's interesting, I was reading the literature, there was an interesting solution. What they did was, there was a study published from the Danish and the Lancet this year, last month. And what they did was, when they faced with this potential issue of healthcare staff shortage during this pandemic, they closed down the 2 university teaching setup, and the medical students were gone to the digital platform. They employed the final year students as temporary residents, and they initiated courses for ventilatory assistance and nursing assistance within 2 days. So they were, as you might know from the history, that Denmark was the first country who dealt with the polio epidemic few hundred years back. So that's why interesting, they have this idea, so they were quite ready to face this pandemic. And now what we have currently got is the staff, so we have to use this staff responsibly. Important points are, we should not lay off or send our employees to furloughs. We have, or we might have to reassign or redeploy our doctors and the paramedics and the healthcare staff, depending upon where we need them in hospital. The important thing is to communicate and update our all staff every day, so they need to be connected to each another and they know what's going on in the institutions. And just keep in mind, when from the OR point of view, we need extra time for gowning and degowning, use of PPEs, and usually procedure time is increased by 1.5 times the usual one. So it is a physiologically stressful situation for the people involved in different procedures. We should keep in mind their physical abilities as well. How to use the employees? Actually, this has to be categorized based on their risk factors. The policy of deployment as per their capabilities. Like in Shaukat Khanam and Anesthesia department, we were faced with this situation, how to keep the OR running with the OR with our anesthesia, general anesthesia services, how to use the staff in the ICU setup, and also for the COVID camp as well. So what we did was to use the minimum staff available for the different procedures. We'll come back to it, and keep in mind it is physically and emotionally tiring work for all the staff. We have adopted a policy of screening for all the OR staff coming to work, and we have also the policy of re-entry of the COVID positive staff as well. So it's also some sort of comprehensive staffing issues, and we developed this policy at the hospital level as well. This is interesting graph as the 3x3 table graph, which was actually published last week in New England Medical Journal, and how they categorize the occupational risk and how they categorize the risk of death from the COVID virus. And if you have read the color coding, this one, the one with the right hand side with the C category, the high is with the older age and middle age who have high risk conditions, and is high if they came across with the patient of coronavirus. So this is the interesting categorization of the how to use your manpower depending upon the risk factor those patient or those employee have. So when you are planning the staffing, you should be careful from this point of view as well. What practically we are doing in our OR is how to use the available OR staff. So what we have done was we are using 2 anesthetic doctors. We have a senior doctor and a junior doctor, 1 anesthetic technician or nurse. Interestingly, if we, depending on the situation, the 2 will be enough, either 1 doctor or anesthesia technician, or even if we have short of anesthesia technicians, so we can use the 2 doctors enough for depending on the procedures. From the surgical side, we are having the main surgeon and 1 or 2 assistants depending on the surgical procedure, 1 scrub nurse, 1 circulating, and 1 HCA outside the door of the OR to bring up the items which are not available inside the ORs. Another important aspect is to avoid the fear epidemic in this situation. You should realize that without support, proper education, training, and a contingency plan, a place like hospital can run havoc with fear, and we need to avoid this situation. Most healthcare workers are brave people and they are happy to take risk. But the important thing is it's easier to risk own safety than to threaten the safety of the family and the loved ones we care about. So we keep in this mind and provide support to our staff working in these circumstances. And the other important thing is what can we learn from the present situation? It's a learning point as well. It's probably going to be professionally speaking and from the sociology point of view as well. This is going to be a game changer in the setup of the society and the hospital setup. So we should consider this as a training opportunity in hospital and outside the hospital as well. We should be adopting to the new practice of social and professional norms, and I hope we will go through this. And we should practice the personal and social hygiene in our society and hospital as well. And we should be using our resources where needed, and we have to avoid the wasting of our resources. Importantly, we should avoid wasting of our manpower in different scenario. This is basically a demographic aspect of the current situation and how we are managing our OR and our anesthesia services in the current situation. And if there is any question, I will be happy to answer. But that's how we are managing. Thank you.
Okay, thank you very much, Dr. Raza, for your kind words and information that you have shared with us. Our next speaker is Dr. On Raza. He is the consultant in infection control and general medicine in Shaukat Khanum Memorial Hospital, and he is going to tell us about anesthesia and infection control measures during the COVID-19 pandemic. So here we go.
Assalamu alaikum. Thank you very much, Dr. Umana, for the introduction. My name is Dr. Raza, and I'm a consultant infectious disease and chair infection control committee at SKM Lahore. Most of my talk is covered by Dr. Asnaf in her first talk. So I'll just briefly give an overview of virus spread, then how surgery is affected by COVID-19 and anesthesia and infection control. Dr. Asma, I think she talked in detail about how this virus spreads. So we all know that this virus spreads from person to person by droplet and infection. It's a droplet infection. And when an infected person coughs or sneezes, these droplets land on the face of another person, and then he can be infected from them. Another mode of transmission is through the contact. And when we contact the contaminated surfaces or objects and then touch our face or our eyes, then we can acquire this infection. COVID-19 has impact on surgery, and during this pandemic, all the elective procedures were cancelled across the globe, including in our hospital. So, but now globally, people are resuming surgeries and elective lists, and we are also in the process of resuming surgeries. So, for COVID positive patients, the surgeries are not indicated and they are not recommended until unless it's an emergency surgery. But for elective surgery, I'll just briefly talk about the preoperative COVID testing and PPE. So why preoperative testing is required? So it is recommended by various societies now, and it was based on this paper which was published in March, and it is a Chinese study in which they saw 34 patients who had surgeries, and they were in the intubation period, and later they all developed COVID-19 infection. And out of these 44% of the patients, they required ICU care, and 22% died. So because based on this paper, it was concluded that if we perform surgeries on COVID-19 infected patients, so the morbidity and mortality we have. Similar, it's a small case series was published in surgery. It was an Iranian study and case series, and they also concluded the same. So American Society of Anesthesiologists and Anesthesia Patient Safety Foundation, they also recommend that preoperative testing should be done. So they recommend that patient should be screened for symptoms, and if the patient is symptomatic, then he should be referred for further evaluation, and all the patients should be tested via nasopharyngeal swabs or PCR testing for COVID. So, for how long we should delay the surgery of positive patients? So, for elective surgical procedures, surgery should be delayed until the recovery. And according to the CDC, there are two strategies. So, one is the test-based strategy, and another is non-test-based strategy. So, first strategy, let's say the resolution of fever without the use of fever-reducing medicines, and improvement in respiratory symptoms, and negative results from two COVID-19 tests, which are nasopharyngeal swabs, 24 hours apart. So this is the first strategy. But they also recommend the second test-based strategy, which says that at least 72 hours since resolution of fever without the use of fever-reducing medications, and improvement in respiratory symptoms, and at least 10 days since symptoms first appear. So these are the two strategies, and we are following this non-test-based strategy here at our center. So next is anesthesia and infection control, and the main goals are prevention of transmission of infection to care providers, prevention of contamination of anesthesia machines and other anesthesia equipment, and of course safety of the patient. So the first thing which comes is the standard. We should follow standard precautions more religiously during this pandemic, which includes hand washing, and it is as I told in my first two slides, that the mode of transmission is through contact as well. So hand washing is vital in this scenario. And then other precautions like using of gloves in appropriate in the situations where we need to wear gloves, proper disposal of sharps, and putting clinical waste in designated bins, and covering out. These are all standard precautions. And then there are transmission-based precautions which we are using for this disinfection, and these are basically contact precautions, droplet precautions, and airborne precautions. So for COVID-19, if we are going to see a suspected or confirmed COVID-19 patient, so we should follow standard precaution, droplet precaution, contact precaution, and face shield or goggles. So which means PPE will include long sleeves, water impermeable gown, gloves, and surgical mask and face shield. But if the patient is having an aerosol generating procedure, then the droplet precaution is not used, and we use airborne precaution, which means that we should use an N95 mask. So what are the aerosol generating procedures? So these are tracheal intubation, non-invasive ventilation, tracheostomy, cardiopulmonary resuscitation, manual ventilation prior to intubation, bronchoscopy, sputum induction, and suction. So it has been discussed in detail previously in intubation that it should be done by an experienced anesthetist, and minimal number of staff should be present in the room during intubation. PPE we have discussed, and proper disposal of intubation equipment. Ideally, in the OR, when the intubation is being taking place, so there should be a negative pressure room. But since our ORs are mostly positive pressure rooms, then the recommendation is that after the intubation there should be a delay of at least 15 minutes before the surgery starts and surgeons enter the room. And then at the end of the surgery, the room should be clean and properly disinfected with the so PPE for anesthesia include gloves, water-resistant gown, which should be long sleeves, face shield, N95 mask. It is mandatory for anesthesia before intubation that they should wear N95 mask, OR cap, and protective barrier, either in the form of clear acrylic boxes or plastic drapes. So we are using plastic drapes with the continuous suction to vent aerosols at our center there. The next important thing is that during this pandemic, initially, people they got infected because they were not following the proper sequence of donning and doffing, and this is very critical in the current scenario, because most of the people, healthcare workers in China, initially they got infected during these procedures. So the proper sequence of donning is we should wear gown first, and mask or N95, surgical or N95 mask, then goggles or face shield, and gloves. And we are going to remove these PPE. We should start from gloves, then should perform hand hygiene, then face shield with goggles, gown, and mask or respirator. We should perform hand hygiene in between each step. Transport of infected patient to OR. Patient should be wearing a mask and should be transported directly. I'm talking about the COVID-19 positive patient who is going for surgery. So should be transported directly to procedure operating room and bypassing the holding area or pre-induction area. And patient should recover from anesthesia in OR and should be transported directly to an airborne infection isolation room for recovery. Then preventing contamination of anesthesia equipment. Should keep, if the COVID-19 patient is in the OR, then keep necessary equipment in OR during aerosol generating procedure, and remove all the unnecessary equipment. Backup or emergency equipment should be kept outside OR, and anesthesia machines and reusable equipment should be cleaned thoroughly and disinfected as per the manufacturer recommendation at the end of the surgery. And ideally, this surgery for COVID-19 positive patient should be performed at the end of the list. Because of this outbreak, there was a shortage of PPE universally, and that's why we people are reusing actually N95 masks, which means that using the same N95 mask for multiple encounters with patient, but removing it after each encounter. And then FDA approved with vaporous hydrogen peroxide disinfection of N95 mask, which we are using here in our center as well. But other possible methods are ultraviolet, germicidal irradiation, or moist freeze heat. Thank you.
Thank you very much, Dr. Our next speaker is Dr. Almas Iqbal. She is a consultant in anesthesia in Shakat Memorial Cancer Hospital. And she is going to talk about the collective, which is actually the term is taken from Star Trek. So anyone who is interested in sci-fi movies, it's a very interesting topic for them. To tell you something about Dr. Almas, she is a graduate of KE and then she decided to go to LUMS and has a gold medal from LUMS in her MBA. Afterwards, she went to England to do her training in anesthesia. And now she is with us working as a consultant anesthetist and going to tell us something about COVID-19 and the collective, and it is related to Star Trek. So here you go, Dr. Almas.
Thank you, Dr. Romana. I'm going to talk about the collective global response that helps a frontline worker. So today we are here, 85,000 cases. So we have a global problem at hand which needs a global response. Two organizations that needs to be mentioned for their for overseeing the emergence and initiating the initial response. WHO, who not only named the disease, but also provided individuals, health workers, and even the countries the clinical care that one needs, and also telling them about the coordination, planning, monitoring, resource utilization, surveillance programs, so the entire package that they gave in terms of information. Information Network for Epidemics, EpiWin, provides a comprehensive information to all the stakeholders. OIC, particularly in terms of the social religious aspects, helped endorse measures taken by Saudi Arabia in cessation of religious activity at the two holy sites. The global information needs to be channelized to the community. So the normal norms that we usually take are having role models, the politicians, the stars that normally, celebrities that are required, community mobilization, giving them awareness about the information that has come through different countries. Information flow through social media is quite variable. The content itself is immensely variable. You would have good stories about it and you would have bad stories. But the impact that social media platforms make is in terms of the amplification. Anything, any story, a video that would get viral in a minute. So hundreds and thousands of likes, millions of viewers of that information. So the speed of that information flow through community is immense. And the context of that information is sometimes missing. It's a superfluous information which is given to public for general consumption. So it's quite compartmentalized. How many words are there in Twitter? So what meaningful debate or information can happen? So that quanta of information is without any strings attached. Individuals who are interested in pursuing their own facts, people who want to confirm their own beliefs rather than finding out the scientific facts, quite like the social media informations which are of variable credibility. So when the epidemic was coming, when this pandemic was coming, what we had in this country, in Pakistan, was that we were a little bit further behind. So other countries had a hit before we had the hit today. There were things that worked well through the social media, and there were things that didn't work well. But what happened with the talk about the airway boxes, video laryngoscopes, the plastic sheet barriers that Dr. Asma and Dr. On talked about, the famous splitting of the ventilators. Everybody went on having a video about splitting of ventilators, the reuse of N95, the drug shortages, all those things helped in one way. It started generating a debate about what is to come, how we are going to counter that with the limited resources that we have. So it really helped us prepare well in advance for ourselves. Then there were credible sources of information, professional societies, Royal Colleges of England, societies, American societies, Russian, Canadian, Chinese societies that we never thought about. They also came to the front and started issuing some resources. They started giving us guidelines, checklists, what to do in these situations. Medical journals, they opened up. Normally you would see the medical journals are behind a paywall, but now people were given free access, professionals were given free access to COVID-related material. There was an enhanced rapid turnover of publications. They speeded it up so that anything, all the material that was coming from China could get published very quickly. So people who are a little bit behind in the pandemic would know what this disease is. So COVID information hubs sprung up, free webinars, webinar recordings, virtual rounds, everything was there on the web, on the internet, and it helped the professionals, not only in terms of the practical issues that they would have, but also the impending psychological impact that the health workers would have, the employee training relationships, and the impact on the trainings. So all these things helped giving professionals credible information, the professionals, those who are very much trusted by the general public. This is the, if you look at the professionals, the personal doctors, they are amongst the top 3 trusted sources of information in Pakistan, and more or less have retained that position over the time as well. Pakistan is very nicely, very well connected technologically, mobile and internet. We have 35% of the people who have internet connectivity and 165 million mobile networks. There is a huge platform there for the information to flow through. So what happens when in a pandemic like this, when the information sometimes is asymmetric? Infodemic is another problem to care for. There are intentionally misinformation planted for things that people are searching for most. So in the COVID, we have 4 areas that people are interested in getting information: the cause of the disease, symptoms and its transmission, treatment, national and local interventions by the government. So the counter strategy that comes through it is, first one needs to identify what do people want the information on, what do they need to know, simplify it, give a simple information to them, give a simple message, but using those stakeholders that belong to that audience so that the audience would listen to them. Use them to amplify your message, using social media technology platforms to weed out the bad information, redirect them to the credible information sources so that this infodemic can be countered. Technology can be leveraged to fight this pandemic. So we have phone, social platforms, we get SMS, we have advertisements over TV, radio and print. We have platforms like WhatsApp, Facebook Messenger, which has a reach from millions to billions of people around the globe. But when that happens, there is a question regarding where to draw the line between the personal freedom of the people and pursuance of public health goals. So one good example of that would be contact tracing apps. You have these contact tracing apps downloaded on the phone, two people who have that app on the mobile, when they meet together, their phones through the Bluetooth technology would exchange a key code, and that key code is uploaded onto the cloud. Now what happens is that if one of the two persons becomes COVID positive and uploads that message that I'm positive now, the cloud would synthesize that information and find out who he had been in contact with, and therefore would take out all the data and send out messages to those who have been in contact. So Pakistan has been doing it, a lot of other countries are doing it. There are big names involved in this market now. Google, Apple, all are doing technological and legislative changes to have contact tracing apps. But contact tracing apps are far better than having contact tracing by history. Because if I'm going to cafe, I don't know who's around me. I won't even know who's around me. So by doing it by app, it would be electronically done and centralized controlled, and therefore would be far more better than somebody calling me up and finding out who I have been in touch with. But the success of this app depends on user adoption. And why is that an issue? Because when we see headlines like Google having a lawsuit to face because they have been tracking data in private mode, it shakes our confidence in what these companies are going to do. And that is not only true for some countries, it is globally. So what would happen to, for instance, a European-owned or internationally owned company with regards to certain other countries? How does technology help us? It helps us with telemedicine. Telemedicine was around for a long time. It was just not being taken up that well. But with this era of social distancing and lockdowns, when patients cannot travel to the health facility and doctors do not want to maintain a social distance with the patient, telemedicine is the one that is coming up. Few minor issues of legislation, health insurances who were previously not agreeing to pay at parity with the physical clinics, all has changed and the environment is far more favorable now. In Italy, in 2 weeks, 1,500 doctors registered and started seeing patients through telemedicine. In Lahore, in private sector, telemedicine has also taken up quite well. Taproots, artificial intelligence, helps in verifying the suspicious symptoms. More than 86 active sessions were done by artificial intelligence in chat roots, and that data was shared with the government and WHO. Active monitoring of services. You don't need to bring all the people to the hospital and see them whether they need to be admitted or sent back to the community. You can do that in the community with the help of the AI. What happens is that the AI would be tracking their clinical parameters. There would be some scoring system, again based on the data analyzed by AI, and then people who do need to come in would come into the hospital and they would be called into the hospital. Video conferencing with the COVID pandemic, lot of conferences, educational events got cancelled, and now they are coming back in form of live streaming, video conferencing, and even social activities are on the by the mode of video conferencing now. Virtual rounds is a concept that the social distancing has to be taken into the medical distancing as well. It's not only that two people of public needs to be at a certain distance. It's the medical doctors who need to be away from each other as well. So what happens in a traditional round? 10, 12 medical doctors would go to a patient's bedside, examine, discuss with the patient, make a medical treatment plan, and document it. So Massachusetts General Hospital, what they did was they had 1 or 2 doctors go to the patient's bedside using the PPEs while the rest of the team joined them virtually. They did the same things in terms of physical examination, seeing them online, then doing the discussion, charting their treatment, but not the entire team had to be in close contact with each other, and there was less use of resources of PPEs. So virtual rounds can help conserve your resources. Video intercom communication systems, having a tab, download app on the patient's bedside. So the nurse does not have to wear a PPE and then talk to the patient physically in the room. She can be outside the room. She can have no PPE and talking to the patient. So the human isolation that comes with serious illness like COVID can be brought down. Families can talk to the patient and they don't have to suffer the consequences of no visitor policy. Digital technology helps in the scientific collaboration of research. Artificial intelligence in terms of machine learning is quite significant in that. If we look at the number of clinical trials which are going globally, it's a huge number. So what happens is that there are a lot of comparisons between the drugs, the treatments that are going on. The trial tracker, what it does is that it downloads collects data from a lot of registry and then removes the duplication. So we are able to see which questions are under research, investigation, and which questions are still unanswered and therefore needs a clinical trial to start on. And similarly, to people who are going to do policy making or research, they have an AI-enabled data search that saves their time. Artificial intelligence in pandemic like these, when a large amount of raw data is coming through, helps us sieve through it and helps us make some sense out of it. Giving you an example of CT chest for patients who are having COVID, artificial intelligence would help us in going through it, because if you have data set of what the COVID CT is supposed to look like, and you develop AI algorithm based on that, and make it an open source so that other countries and other institutions also can benefit from it. They can do minor adaptations based on their local context, but overall, what would happen is that you do not need a radiologist time 100% to look at those CT scans. The AI would enable the process and save the time of radiologists. So 3 main domains in which it can help. I'll take up the clinical one. So AI helps in not only diagnosing, like image-based diagnosis, the CT chest that has been talked about, but also in the tracer technology. Where are those people with the downloaded applications moving around, who they are meeting? So you get the clusters of COVID positive populations. Where is it growing more? So you can have an eye on where the resources are going to be utilized most. Also in terms of the treatment and follow-up, remote monitoring and telemedicine that we talked about. Artificial intelligence is quite useful if you have infodemic, an overload of information and a misplaced information in between somewhere. So what artificial intelligence does is monitoring of the social media platforms. Anything that comes in terms of its trends, any hate speech, any kind of verbal attack, any specific kind of searches that people are making to understand a phenomena, that all can be tracked by artificial intelligence. And that helps us understand what our people need to know and what needs to be curtailed and what needs to be given out to them in a more simpler way. In epidemiology, Artificial intelligence would help us in making public policy interventions. For instance, when we talk about the smart lockdowns, artificial intelligence would help us in locating people. If in a region there is a surge of helpline phone calls by a specific locality, or if people of certain locality have started going more to hospitals, or if there is an increase in, for instance, chest-related symptoms in a certain area, then that would help us locate those regions and do smart lockdown in those areas rather than widespread lockdowns in even low affected areas. That would have other consequences in terms of economy. So what do we need to do? We need to think globally and share our experiences, but actions are done locally in a more decentralized approach. NDMA is our command and control center, and it is the one that helps us lead in local propagation of information, the information which is relevant to our circumstances locally. What do our people want to hear? Innovation and preparation, for instance, the PPE shortages, the supply chains, how variable they are, what kind of preparation that would be required, the local bioethics involved, and even the hospitals and professional societies who have developed living guidelines, a practical and future-directed document that has flexibility as the situation changes. The telemedicine and the helplines that have come across the country, and even the video linking, collaborative softwares who would help us connect in the time when we can't connect physically. So as the life goes on, the telemedicine, the technology, and the information, these are the things that would help us because the life goes on. Thank you.
Thank you very much, Dr. Mas. And Dr. Mas, again, I would like to say AI, artificial intelligence, is also Dr. Mas Iqbal. So this was the last speaker, and now we have received few questions. The first question is for Dr. Asma. So the first question for Dr. Asma is that you said that intubation is being performed by the senior anesthetist. So the question is that how do you define the seniority of the anesthetist who is supposed to do the intubation? We're talking about the COVID intubation, so I would like Dr. Asma to please answer this question. And the next question is for Dr. Raza. All right, so Dr. Asma is not available, so I would give you the answer on this question. The senior anesthetist is defined as the anesthetist available on the floor at that time, who is the senior most. We have decided in our meetings that it will be the consultant anesthetist. So all the COVID intubations have been performed by the consultant anesthetist, especially the elective ones. The consultant anesthetists have been called from home to come and do the intubations. The only intubations that were done by the resident anesthetist are the ones that are the cardiac arrest situation when it is not possible for the consultant anesthetist to be there in that very moment of the time. The next question is for Dr. Raza, which says that before starting elective surgery, what measures were taken? So according to him, he says that since it was the cancer surgeries, we couldn't delay the cancer surgeries, and we had actually done all the donning and doffing drills before we started this. All the consultant anesthetists were the ones who actually did the drill first, and when they were perfect in their donning and doffing, then the residents and the technicians were also made to do that drill. Also, along with that, every single patient that is coming to the theater is being treated as suspected corona patient. So we do all the donning and doffing for every single patient who is coming. And now recently, hospital has started doing the COVID testing for each elective patient who is coming for the surgery. Then we had another question for Dr. Athar, which was that among all the controversies cited, which controversial managements are being used in ICU. So since Dr. Athar is not here and I don't do the ICU, I won't be able to answer this question. With all this, I wrap up this webinar, and thank you very much for all those who have been listening this, and we'll be back soon in the next couple of months to do another webinar on the pain medicine and COVID. Thank you very much. Good luck and goodbye. Stay safe, stay home. Allah Hafiz.